I am Dr. Hikmat, working as a senior registrar cardiology at Civil Hospital Koita. My today topic will be about the the peripartum cardiomyopathy. So first of all, I will discuss about the clinical criteria. So development of the cardiac failure in the last month of pregnancy or within 5 months after delivery. And there should be absence of any recognizable cause for that cardiac failure. There should be also any recognizable cause, absence of any recognizable cause prior to that last month of pregnancy. And the LVEF on echo should be less than 45%. This is the clinical criteria of peripartum cardiomyopathy. And then there is overview of peripartum cardiomyopathy. Echocardiography is the primary diagnostic and follow-up tool. It has two phenotypes. It may be dilated, the LV may be dilated or non-dilated in peripartum cardiomyopathy. Now, ये चेंज नहीं हो रही स्लाइड चेंज कर लें हैंडली Now, and there are certain echo criteria to diagnose the peripartum cardiomyopathy. The first one we discussed already, that LVEF should be less than 45. There will be systolic global, or there will be global hypokinesia, no regional wall motion abnormality. LV may be dilated, already discussed, or normal sized, and we can also have LV diastolic dysfunction. This is the echo criteria of peripartum cardiomyopathy. Now, we'll also discuss the incidence. The incidence is very much variable. It may be one in 4,000 pregnancies in the West to maybe 1 in 100 pregnancies in the African countries like Haiti. They say that up to 7% of these peripartum cardiomyopathy occurs in the last month of pregnancy, and this incidence increases maybe 60% within the first 2 months post-delivery. Now, the etiology is also multifactorial. The exact etiology is unknown. They say that multifactors may be nutritional deficiencies. Selenium has been considered as the most common cause. Maybe hormonal effects, toxemia, or maybe maternal immunologic response to fetal antigen. Degradation products of prolactin, which are toxic to myocardium, has also been studied as a cause, and myocarditis is also considered maybe a cause of peripartum cardiomyopathy. Now, risk factors are those ladies with age more than 30, multiparous females with African descent, maternal cocaine use, long-term use of tocolytic therapy for more than 4 weeks, pregnancy with multiple fetuses like twins or triplets, and well, there is a history of pre-eclampsia, eclampsia, or postpartum hypertension. These ladies are at risk of developing peripartum cardiomyopathy. Now, the approach should be, we must go for baseline investigations, chest X-ray, echo, of course, biomarkers, anti-proBNPs being heart failure, CRP, and then this 16 kDa prolactin. This is a key pathophysiologic fragment for the diagnosis of this peripartum cardiomyopathy. And then interferon, it is a prognostic marker. And then microRNase 146, a novel biomarkers for peripartum cardiomyopathy. It differentiates peripartum cardiomyopathy from other types of idiopathic cardiomyopathies. So this is a novel marker. ये आगे चेंज नहीं हो रही, काइंडली चेंज कीजिएगा. Now, coming towards echo, we are discussing the role of echo in peripartum cardiomyopathy. In echo, we may have all 4 chambers may be dilated with reduced LVEF, already discussed, and there may be small to moderate pericardial effusion. There may be MR or TR. We know that it is a cardiomyopathy, so pulmonary pressures may be raised, LA may be enlarged. And then we can also detect complications of peripartum cardiomyopathy based on echo. LV apical thrombus, the high prevalence due to hypercoagulability. Spontaneous echo contrast may be elevated, and there may be pericardial effusion present. Now, detailed RV functional analysis, TAPC, RV FAC must be done. Pulmonary pressure must be estimated, and punctal MR, TR must be graded. This is a apical thrombus found in peripartum cardiomyopathy patient. Again, secondary MR present in peripartum cardiomyopathy. Now, advanced imaging like JLS has a significant role in peripartum cardiomyopathy. This has higher sensitivity, even so than EF detects subtle myocardial dysfunction. JLS detects early LV dysfunction even if the EF is preserved. Impaired JLS at presentation reflects more extensive myocardial involvement. Worse JLS predicts delayed LV recovery, useful for therapy monitoring and prognosis. Best modality for risk stratification. Now, the role of CMR. CMR is helpful for myocardial characterization when echo is inconclusive. Can differentiate peripartum cardiomyopathy from myocarditis, ischemia, or genetic DCM. Echo remains the first line modality in this case. Now, management of peripartum cardiomyopathy, acute presenting like heart failure, so acute management, and chronic, we all know that we must give all the 4 pillars to these patients. We will manage the peripartum cardiomyopathy just like a routine heart failure patient. Now, there is a question that we are cardiologists, we are also having practical patients in our OPDs, in our wards, that we are given calls by the gynae department how to deliver these patients. So timing and mode of delivery needs a multidisciplinary approach. Peripartum cardiomyopathy with compensated heart failure. The patient is stable, she is compensated. So normal delivery, general delivery is the preferred mode of delivery. On the other hand, C-section is preferred only for the obstetric indications or critically ill patients on inotropic support. Epidural anesthesia is the preferred mode of anesthesia. Women who did not recover LVF more than 50%, they should avoid future pregnancies. Breastfeeding, controversial initially. It was controversial according to the ESC guidelines because in the initially breastfeeding, the prolactin level increases in the early stages. But currently they say that allowing breastfeeding with careful medical supervision. Now, there is another drug that is called bromocriptine. Now, according to ESC guidelines, for heart disease and pregnancy, bromocriptine is class 2B. So there are 2 regimes if someone wants to give, especially the regime is best for severe LV dysfunction. Now when EF is less than 25%, these ladies can be offered with bromocriptine. Again, but if you are giving bromocriptine, there should be anticoagulation along with this bromocriptine. Now, what are the differential diagnoses? Pregnancy-induced hypertension. But the heart failure due to pregnancy-induced hypertension represents a diastolic failure. But here in peripartum cardiomyopathy, it is systolic heart failure. The other differential is pulmonary embolism. Patient who presents with shortness of breath, dyspnea in pregnancy, we should also have these differentials in our mind. So, for pulmonary embolism, rule out by chest X-ray, and if we see suspect, we go for CTPA. So, echo. Let's see. Prognostically, how echo helps lower baseline EF associated with poor recovery. Larger LV dimensions indicates chronic remodeling and worse outcomes now. RV dysfunction, strongest predictor of mortality. Impaired JLS predicts persistent LV dysfunction. Now what is the follow-up of echo? Echo should be recommended at 3, 6, and 12 months. Normalization of EF plus JLS needed before therapy de-escalation. So once you think that your EF as well as JLS both are normal, then you can de-escalate the medical therapy. Essential before planning future pregnancy. Echo is essential. Stain imaging essential for prognostication. RV function must always be assessed in every patient with peripartum cardiomyopathy. Serial echo strongly influences therapeutic decisions. Now, prognosis. Good prognosis for from all other forms of cardiomyopathies. This is the only cardiomyopathy with the best prognosis compared to other forms. 50% patients completely recover. 25% of the patients, they persist with symptoms. 25% of the patients develop complications, like they may develop heart failure, they may develop arrhythmias or thromboembolism. and mortality is 3 to 9.6%. Those patients, very important sentence, those patients with persistent cardiomyopathy after the 6 months with therapy, if they have persistent cardiomyopathy, persistent LV function, their mortality is 85% in the next 5 years. Thank you.